afternoon. I'm Jarman. I'm going to sort of moderate this session. It's wonderful to be here, and we appreciate you all coming. I'm just going to give a brief introduction of kind of what we're going to talk about, where we're going, and we're going to jump right in. I want to start with a brief anecdote, though, which I thought was really powerful, something that happened maybe today, maybe this week, in protection of this person's anonymity. But because we're ER doctors and do things last minute, I went to some facility in some city to print handouts for today, to print cases. And the person that worked there had to pull up my file and said, okay, you know, front and back, what do you, blah, 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 details. And then she said, do you work here? Are you from Indiana? And I said, no. I thought it was a bizarre question that she asked me. And I said, no, I'm coming from Rhode Island, which I am. And then it died in the water. And then a few seconds later, she said, oh, because my daughter has this problem. And this was as she had pulled up a handout that said, you know, transgender was the key word. And she said she was having a lot of trouble finding a doctor for her daughter to see, that the wait list was 6 months. So I think that just underscores exactly why we're here to talk about this, because there's a huge need. So I thought that was a really powerful thing that happened today, and just kind of keep that in mind, that that's why we're here. Can you all hear okay? Yes? Okay, great. So these are our objectives for today. I won't read them to you, but essentially we're going to talk about some vocabulary and common terms that we should all be fluent with in caring for this population. We're going to talk a lot about communication and how to do that well, a little bit about social determinants, and then just kind of how to take better care of these patients comprehensively. This is just a little bit of a roadmap to let you know where we're going. We're going to start with some personal stories, other than my anecdote. And then we have enough people here. We're going to break up for only about 10 minutes and talk about a case. The purpose of the case is to essentially generate questions. So keep that in mind when we talk about the case, to think about how you would handle this and what questions you have. And then finally, we're going to close with an expert panel. And with that, let me introduce the panel. First, we have Dr. Bruce Becker, who's a professor of emergency medicine at Brown Medical School. Then we have Tracy Madsen, who is an assistant professor also at Brown. We have Dr. Moll, am I pronouncing that correctly, who is the program director and at VCU in Richmond. And then finally we have Liz Samuels, who's currently at Yale but coming back to us at Brown, which we're really excited about. So thanks to you all for being here. And with that, let me turn it over to Dr. Becker.
Great. We're going to start. I have 4 short scenarios, which are as lived, recorded, consented interviews, which were done last summer from folk from the LGBTQ2S community who were talking about their experiences interacting with the medical system and us. The first one is called Asking. I openly acknowledge that I'm a gay man and I am HIV positive. I was admitted to the hospital and a resident came in and he wanted to know if he could ask a few questions. Of course, I said yes. It's a teaching hospital. I'm good with that. But then he started. So, I see you're HIV positive. And I'm like, yeah. And he goes, so are you still sexually active? Yeah. He goes on, do you think you got HIV because you were receiving or giving? And then he got really specific about the details. I told him to get out of my room. Do not come back, ever. You're not allowed to ask those questions. I will not answer them. He was intrusive. He was trying to shame me. It was a horrible conversation. Go stick your judgment. Number 2, naming. Your legal name should be on the 13th page of forms, the last page, hidden under pages and pages of other records. It's not useful or helpful. I see why it needs to be on there, but it causes confusion that is just hurtful. One of the most meaningful things the medical system could do would be to make forms that address trans needs and queer needs. I'm sitting in the waiting room just thinking or minding my own business or staring at the wall and they dead name me. A name I haven't heard in years, and I panic. I had to stand up. I'm outed in front of the whole waiting room. I like to present fairly femininely, and my birth name isn't gender neutral. It's how coming out happens all the time. To the waiting room, to the nurse or the doctor, to the mailman or bank teller. So sure, I'll tell him I'm trans, but I just want to put it down on the form. Then they'll have my preferred name, my preferred pronouns. That's the name they'll see. That's the name they'll use. Easy for everyone. It's so hard to stand up and react to that other name. It feels like this dragged around part of me. I understand why they have to have it. There's just no reason they have to use it. I want to be comfortable at the doctor's. I want to be able to ask questions. But already my heart is racing. I'm struggling to breathe because I don't know what those people are thinking. I see the confusion and the strange look on the face of the person who said it when I stand up. They want to say something like, "Excuse me, this isn't you, but it is me." Or it was, and I'm just trapped. It doesn't matter that trans women get UTIs at an astounding rate, or that I'm here to be seen. I need medical care. I just want to leave and never be in this situation again, and we haven't even started. Judging. In the ER, I always am uncomfortable when they ask, "What medications are you on?" And I say, Truvada. I just don't know what kind of reaction I'm going to get. There's a lot of judgment. I explain what the drug is and why I'm on it. I say this thing, and then I'm giving these people fuel to judge me. And then I'm asking them to think of me as one of the good ones, because it means I'm HIV negative, that I'm tested regularly, that I take care of myself. That's what it means for me. It means I'm lucky. I have a job, insurance. But there's all this internalized homophobia that I'm fighting, when really all they should want are the names of my drugs and doses. Listing my meds shouldn't be the hardest part of the ER visit. And lastly, damning. I'm in an STD clinic. This guy sits down next to me and starts checking Grindr right away. There's a mannequin in a corner wearing a dress made up of antiretroviral drug containers. I kid you not. My tester is 50-something-year-old with tattoos all over, bald except for a single ponytail of gray hair dyed fire red. He called gonorrhea and syphilis trendy and fashionable diseases. He walked in and just started asking me about my sexual habits. Did you have unprotected sex? No. Did a condom break? No. Did you have sex with a stranger? I have to reply yes to that one. Then he seemed to settle in like this was some ordeal. When was the last time you had anal sex without a condom? And when did you last have oral sex without a condom? He penciled in a number before I even answered. Then he went on a very long rant about every possible way I could possibly get in contact with what he called gonorrhea juices. You could be getting ready. He could be unrolling the condom and suddenly realizes he's unrolling it in the wrong way, flips it inside out, and sploosh. You could be dancing at a club and meet a hot guy. You start kissing. Your tongue goes over the syphilis sore he has hidden in his mouth. Bang. He told me to come back every 3 months. The recommendations for men who have sex with men, particularly men like me who have sex with strangers, i.e. new partners. So I go back in 3 months and I'm scolded by the nurse for getting an STD test. Isn't this what I was told? She says, "I see on your form that your last check was February. Why are you back so soon? We're having budget cuts in this department." And I say, "Do your budget cuts mean I shouldn't come in?" I wanted to make up some story of me going to a crystal meth bareback orgy, if she's going to assume the worst of me anyway. But I said, "I've undertaken some risky behavior." Then I said, "I got home from a party and found glitter on my face. You know, glitter is the herpes of makeup. I'm pretty sure I need a test for genital herpes." I come in and there's judgment about who I'm seeing or what I'm doing. They're asking all these intimate questions. I'm in the clinic being a medically responsible person, doing what I've been instructed to do, and the nurse is making me out to be some sexual deviant. I just wanted to get tested. Damned if I do, and damned if I don't.
Thank you, Dr. Becker. So we would really like to try to break up into a few small groups. So let's see if we can fashion 4 groups out of this, keeping in mind that this side of the room is smaller than that side. We're going to come around and join you and talk about a case for a few minutes. Try to think through that and come up with some questions, then we'll come back together and address those, okay?